Everyone, and welcome to my channel, Medvas. And today we are into a very important topic of pathology, which is ovarian tumors. So we'll discuss the ovarian tumors. We'll discuss the tumors which is generating from the surface epithelium, from the sex cord or the stromal tumors or the germ cell tumors, right? So ovarian tumors can be classified basically into the surface epithelial tumors, sex cord or stromal tumors, and germ cell tumors. Okay. So you have to understand this basic fact. So let's come into ovarian tumors. I will not write much because there are very many things to write. I will just tell you and write only the important things which are important for your exam, most important things. So if you have to draw, you can draw the ovary like this, and let's assume this whole part, the epithelium. Let's say this is the epithelium of the ovary, and this yellow part with the stroma which is there, and let's draw a germ cell or the ova. Okay, yeah. So we have our surface epithelial tumors. We have some stromal tumors. We have germ cell tumors. Understood? So in epithelial tumors, what we have, we can have in epithelial type of tumors, we can have a variety of classification like serous epithelial tumors. Serous. We can have mucinous or mucous epithelial tumors. Mucinous, you right, it is a better word. Mucinous epithelial tumors. We can have endometrioid, clear cell, Brenner, many things are there. Endometrioid, clear cell, Brenner tumor of ovary. Okay. And we have some mixed epithelial tumors. Mixed epithelial tumors. Mixed epithelial tumors. We have some types of, you can say, undifferentiated tumors as well. Understood? And in germ cell tumors, in the germ cell tumors, we have teratoma, dysgerminoma, yolk sac tumor, choriocarcinoma. Teratoma, dysgerminoma, choriocarcinoma. Teratoma, dysgerminoma, choriocarcinoma, and yolk sac tumors. So these are the germ cell tumors. And then we have a category of stromal tumors. A category of stromal tumors. And this stromal tumors are also called the sex cord tumors. The sex cord tumors. Here we have some granulosa cell tumors or the thecal cells tumor. Okay, you can write here. Granulosa cell tumor, and we have fibromas, we have fibroblastomas, we have gonadoblastomas, many things are there. Fibromas, fibroblastomas, gonadoblastomas, and so now let's talk first about our teratoma, right? Teratoma. Teratoma. So what about teratoma? Teratoma, the origin of the teratoma are the totipotent stem cells, right? So the origin is the totipotent stem cells. This totipotent stem cells can give rise to all the three germ layers. So this teratoma is a tumor which is comprised of, you can say, all three germ layers. It can comprise of all three germ layers, and the teratoma can occur in a variety of regions like ovary, testis, then CNS even. Okay, CNS even. So this produces a kind of lesions which is called as the midline lesions. Midline lesions. The middle line of the body. Why it is a midline lesions? Because they affect the midline of the body. If this is a human, they affect this all parts. So they are called as the midline lesions, right? And now let's come to ovarian teratomas. Okay, ovarian teratomas are basically benign lesions. So ovarian teratomas are basically benign lesions. They are not malignant in nature as well. And this may be classified into again three types, that is mature cystic teratoma, immature teratoma, monodermal teratoma. So ovarian teratomas can be classified again into three categories, that is mature, you can write one, mature cystic teratoma, immature teratomas, and third one mature cystic teratomas, immature teratomas, and the third one is monodermal teratomas. I hope you don't have any problem if I'm using this kind of pen, because I personally like this kind of writing. That's why I'm using this. If you feel any difficulty in that understanding, do tell me in comment section. Otherwise, I will continue to use this kind of pen, and you won't understand. Okay. So mature cystic teratoma are the majority of tumors. The majority of teratomas are mature cystic teratoma only. 80 to 90% you can consider mature cystic teratomas. Okay, 80 to 90%. And this the age group which is commonly affected are 20 to 40 years of age. Okay, and this the patient will present with an abdominal mass. Patient will present with an abdominal mass. Okay, and these are cystic lesions. These are basically cystic lesions, and here importantly, as all three germ layers are contributing, so we can have here in the gross appearance, we can have tooth, hair, sebaceous glands, all the mesenchymal components, cartilage may be present. Okay, in this tumor. If you excise the tumor and see, here you can see a tooth, you can see nails, you can see bone, cartilage, all may be present since it is comprises of all the types of layers. And cystic lesions with solid areas, some solid areas are present over here. Cystic lesions with solid areas, and the solid areas in the things are called as the Rokitansky protuberance. This is an important word. So I'm writing with this. Rokitansky protuberances, right? And in the microscopy, the teratoma has all three germ layers that will be present. Okay, so in microscopy, we have all three germ layers in the microscopic find. Understood? So that was about the cystic teratoma, and now let's talk about the immature teratomas. Okay, immature teratomas. Immature teratomas are, remember, these are highly well differentiated tumors. Highly well differentiated tumors, and this if you see the histological slide, you can say, okay, you can remember like this. We have a blastic epithelium which is found here. Okay, you can just write that we can have a blastic epithelium, a primitive epithelium, which you can find. Okay, we have a primitive epithelium present. Primitive epithelium present. And this monodermal teratomas are, you remember, it is the most highest specialized, very well differentiated. This is very well differentiated. And if you see the appearance, you can see, if you see the appearance, you will see something like this, that it will If you, these are the, let's say these are the cuboidal cells. I'm drawing the normal histology of a organ. Just say which organ is this, and here, and we have the parafollicular cells here. Okay, I told parafollicular cells, so this appears like thyroid, right? So here, if we see the monodermal teratomas, they somewhat appear like the thyroid gland only. Okay, the microscopy, the most common, they invade into the thyroid component. So these have a special name, which is called the stroma ovary. Stroma ovary. Stroma ovary. These have a special name. Okay, as they invade into the thyroid components. So that was about our teratomas, the first tumors, and now let's move to the dysgerminomas. Dysgerminoma. After teratomas, this all you can take a screenshot if you want. These are about the teratomas. The most important things, occurrence sign, protuberance. They will ask you. They will ask you stroma ovary. What is stroma ovary? They will ask you types. They will ask you what is teratoma. You can answer each of this easily. We don't need to go into much more detail. Robbins has covered in full details, but I have taken only the important facts which you need to understand. You need to know. Okay. So you can take your textbook and read and feel confident about this topic. Okay. Yeah, I will suggest you to read this topic from Robbins as after the lecture, right? Okay. And this germinoma. So what is this germinoma? It is the most common malignant germ cell tumor in females. Remember, this is the, I'm writing GCT in females. This is an important line. Okay, most common. This is the most common. And the presentation is again 20 to 40 years. They'll present 20 to 40 years of age, and a person with a gonadal dysgenesis or hermaphrodite, a hermaphrodite person, okay, have a high risk of dysgerminoma. So risk factor, you can write risk factor, a hermaphrodite, you can represent it like this. Okay, as a high risk factors. And if we talk about the gross appearance here, the gross, so the gross appearance, what will be the gross appearance? It is a fleshy tumor. It is a brain-like appearance. Important. This line is important. It has a brain-like appearance. Brain-like appearance. That is, it is a fleshy tumor. It is a fleshy tumor having a brain-like appearance. And it can have hemorrhages as well. It has a syncytial trophoblastic differentiation. So it may be associated with hemorrhages. May be associated with hemorrhages, right? And if we talk about the microscopy, we have the the nests of tumor cells which is present, nesting pattern you can say, the nest of tumor cells, and within the nest of tumor cells you have the lymphocytic infiltration. In the nest of tumor cells you have an lymphocytic infiltration. So if we talk about the appearance, so we have like this, something like this. So let's say this is the nest of tumor cells. This is a nest of tumor cells. I am copying this. So here another nest. Let's say here another nest. Here another nest. Okay, so nest of tumor cells, and this will be interspersed in the stroma. We'll have the lymphocytes present. So lymphocytic infiltration. This is the lymphocytic infiltration. So here we have nest of tumor cells and lymphocytic infiltration. So this is the microscope. Done. So that were the things that you have to know about dysgerminoma. And if I talk about the immunohistochemistry, okay, immunohistochemistry is something called the NaNOG. and OCT3 and 4, OCT3 and 4, and SAL4. So NANOC positive, OCT3, 4, and SAL4. You can remember this if you want. Okay, they're given in neurons. So that were about our teratomas and dysgerminoma. Let's now move to the yolk sac tumors. Let's now move to the yolk sac tumors, and we'll see a very special body here in the yolk sac tumor. It's called the ciliary duval bodies, or ciliary duval bodies, or the glomerular bodies. Let's see. So yolk sac tumors. So in yolk sac tumor, the first thing which you have to understand is it is an endometrial sinus tumor. It is an endometrial sinus tumor. So in the distended areas, it opens the sinuses of the endometrium, and age is you can say presents when the child is less than 5 years. Generally, it presents when the child is less than 5 years of age. So less than 5 years is the age of presentation in the children, and it is a malignant tumor. The most important thing is that it is a malignant one. It is a malignant tumor, and in the gross, you will see solid and cystic areas. So in the gross, you will see again a biphasic type of appearance, solid plus cystic areas, solid plus cystic areas. And here in the microscopy, a very special appearance is seen. You can see here. Let me draw for you. So let's say this is a blood vessel. Let's say this is a blood vessel, and this is a layer of tumor cells. These are the tumor cells which are surrounding the blood vessel. One layer, and then another layer, another layer. So this appearance basically is called as the Schiller Duval body. Schiller Duval body. Schiller Duval body. So a you can say blood vessel is surrounded by next two layers. You can say two layers of tumor cells, right? So this is these are the tumor cells. You can mark this tumor cells, and this is the blood vessel. So that were about our this. Okay, this Schiller Duval body is also called as glomeruloid body. Glomerular body. Understood? So that were about the things you have to know. And here, if we talk about the immunohistochemistry, we have the it is an embryonic tumor, yolk sac tumor. Okay, yolk sac tumor. So you can remember like this, that we have in immunohistochemistry we have alpha fetoprotein positive, AFP will be positive, and alpha 1 antitrypsin is also positive. These things you have to remember, right? Understood? So yolk sac tumor is done, ciliary body is done, glomerular body which is called, and granulosa. Then we'll move to the other tumor, that is the granulosa cell tumor. Okay, we'll move to the granulosa cell tumor, and here the characteristic microscopic appearance will be a coffee bean nuclei or a col exner body. Okay, col exner body. We'll see in due course of time. So let's move on to granulosa cell tumor. Okay. So here we are done with this germ cell tumors. Okay, teratoma, dysgerminoma, choriocarcinoma is just the same. The immunohistochemistry will again be this alpha fetoprotein. Okay, choriocarcinoma is basically the tumors derived from the chorionic membrane or chorioantic membrane. And we talked about yolk cell tumors. So we are done with the germ cell tumors. Now we have moved into the stromal tumors. That is, first we are discussing the granulosa cell tumor, right? Granulosa cell tumor. So granulosa cell tumor, this tumor it occurs mainly in adults. Okay, 90 to 95% cases are in adults only, but the juvenile also. Okay, and remember the most specific thing which you have to remember about this. It is an estrogen secreting tumor. It will increase the estrogen. If it increases the estrogen, there will be a endometrial hyperplasia, right? Due to increased estrogen, the endometrium multiplies. So it will be endometrial hyperplasia, and it can lead to menorrhagia as well. Can lead to menorrhagia as well. And due to estrogen secretion, if it occurs in childhood, it will lead to precocious puberty as well. Okay, so it can lead to menorrhagia, and it can lead to precocious puberty. To precocious puberty, and this all these things are happening due to increased estrogen secretion by the tumor. Okay, so menorrhagia and precocious puberty are happening due to increase in this. And talking about the gross appearance, it is a unilateral tumor. It is a unilateral tumor, and solid and cystic areas are present over here only. And due to this steroidal hormones, due to this estrogen, there will be a yellowish appearance. So yellowish color of the tumor is due to the secretion of this steroidal hormones, right? So in gross appearance, we'll see three things: unilateral. First thing is the unilateral. Second thing is the solid and cystic areas are present, and it has a yellowish appearance. Okay, done. And now let's talk about the microscopy. So talking about the microscopy here, we have something, a characteristic appearance known as coffee bean. Coffee bean nuclei you can write, and plus and other thing which is called as the Call Exner body. I will tell you what is Call Exner body, and this is called as the Call Exner bodies. Call Exner body. So basically, what is Call Exner body? We have a pink cell here. This is the pink cell. In oncocytic cell, you can consider pink cell, and this pink cell is surrounded by the tumor cells. This pink cell is surrounded by the tumor cells. These are the tumor cells. And this coffee bean nuclei means the nuclei is shaped like a coffee bean. So these are the you can say things which are important. Okay, the microscopy. And immunohistochemistry, there will be inhibin present. Important thing, as estrogen is present, right? So IHC marker you can write inhibin. Inhibin positive. Done. So that's all in the granular cell tumors. Next, we'll start with the epithelial cell tumors. Okay, the tumors of epithelia. Okay. Okay, so talking about epithelial tumors, you cannot see my video just because I got disconnected out of that call. And let's finish this topic. I guess you don't have any problem without any video, and you can focus. But from next time, I will again start with the video on. So epithelial tumor, we know the lining epithelium of the ovary is cuboidal to columnar type of epithelium, and epithelial tumor can be serous, can be mucinous, okay, and can be epithelioid, you can say, clear cell, and transitional. Okay, this transitional tumors which I previously talked about are the Brenner tumor. Look at this, where we are talking here. Look at this. So epithelial tumors, we had serous, we had mucinous, endometrioid, clear cell, Brenner, or this is also called as transitional. Okay, transitional. Then mixed epithelial and undifferentiated type of tumors, right? So that were the things. And each type, like serous, each type, so it will have three classifications. It will have a benign counterpart, it will have a borderline, and it will have a malignant one. Then mucinous also three types, endometrioid also three types, clear cell also three types. So each of this will have three types of classification. So you can imagine how complex it is to classify the epithelial tumors. But we will do up to what we need from an undergraduate level, and then we'll leave that all to the oncologist to study. And if in future you plan to become an oncologist, you have to study this, right? Okay. Let's talk about serous tumors.
serous tumors. Serous tumor. So if I talk about serous tumor, it's the most common epithelial tumor. You have to understand that it is the most common epithelial tumor, and here the problem is that like it occurs. It is an intraepithelial carcinoma. You can say it is an intraepithelial carcinoma. Intraepithelial carcinoma means it occurs in the fallopian tube basically. Okay, it occurs in the fallopian tube, and fallopian tube means the tumor cells can migrate, right? If it occurs like this, you can just a minute, let me draw it a bit. Let's assume this one. Okay, drawing is, you can manage the drawing. Let's say this is our ovary. This is our ovary, and here we had the processes, the femori. The femori are there, and this is the ligament which is joining, right? So this tumor cells, if this occurs in the fallopian tube, this tumor cells basically, I'm drawing the tumor cells in red. So these are the tumor cells. These tumor cells, they can migrate here and can reach this ovary only. Okay, so here the tumor cells can migrate downwards also. So if a patient comes to you with this tumor, you have to do the whole removal. You have to remove this all. You have to do the whole removal here, and this removal process is called as the bilateral salpingo-oophorectomy plus total abdominal hysterectomy. So you are removing the ovary, you are removing the fallopian tube, ovary, as well as the uterus, right? So that is the thing in the serous tumors. And here the genetic cause is the genes which are responsible are the BRCA1, BRCA1 or 2. It may be associated with BRCA1 or 2, and BRCA is associated with the breast carcinoma as well. And in the gross appearance, you will see serous tumor means there will be papillary projections, there will be psammoma bodies. Okay, so here we will have papillae. You will write papillary projections, and in microscopy you will write psammoma bodies projections, and in microscopy you will write psammoma bodies and hold appearances, psammoma bodies. And the mutation associated with this, is the p53 mutation. If it is associated with this mutation, or you can say immunohistochemistry, this one, then it has a worse prognosis. Of course, you have to remove these all parts, means the tumor is definitely a deadly tumor, right? So that finishes our serous tumors, and now let's move on to mucinous tumors. Okay, mucinous tumors. Just a minute. Mucinous tumors. So talking about mucinous tumors, what about the mucinous tumors? So here, these are the 20 to 25% of ovarian tumors and mucinous tumors, and these are very big tumors. These are big tumors, really. Okay, these are really big tumors, and here they are common in perimenopausal age group. An important thing is that it's common in perimenopausal age group. And this can be benign as well as malignant. And grossly, what will be the appearance? If this is the tumor, let's assume this is the tumor. Okay, this is the tumor. Then there will be cysts like spaces present. Let's say this color, some cyst like things are present here. Let's say these all are cysts, and here we'll have the filling of the clear fluid, which is the mucin. Okay, so here we have in the gross appearance, we'll have our cysts filled with mucin. This is the gross appearance. You can know from the name itself, right? And the solid areas are also present. This microscopy, you will see columnar epithelium will be there, right? So microscopy, you will see columnar epithelium plus mucin will be there, plus glands will be there. Okay, plus glands will be there. So this is the whole thing, microscope. And these are most commonly, just remember, these are most commonly benign rather than malignant. These are benign rather than malignant, right? And this mucinous carcinomas also, this mucinous tumors can spread and can breach the capsule and go outside. It can spread to the peritoneum also. Okay, this mucin and this tumor cells can spread to peritoneum and can cause a phenomenon which is called as the pseudomyxoma peritonei. Pseudomyxoma peritonei. Pseudomyxoma peritonei. Pseudomyxoma peritonei. Okay, pseudomyxoma peritonei. And this can be seen in the mucinous carcinoma of ovary, of colon. Okay, and all this. And if this happens, then you know the patient is about to die. You have to prepare your dialogues, I can say, and intimate the people who the attendants of the patient in a very decent way, so that they will understand. Okay, you have to deal with these situations very soon, so be prepared. So they have a worse prognosis, right? Okay, so that's about mucinous tumors. And now let's come to endometrioid tumors. Let's come to endometrioid tumors. Okay, today's notes are looking very good, right? Yeah, I don't know how we're finding, but it's looking good. Endometrioid tumor. So what is the precursor lesion here? Every tumor is a precursor lesion, so we have an important precursor here. The precursor is said to be ovarian endometriosis. You know about endometriosis, right? So ovarian endometriosis is the precursor lesion, and here if there is a ovarian endometriosis associated with it, we have KRAS or P13KA mutation, KRAS or P13KA mutation, then it grows and become malignant, right? So this is about the endometrium tumor. And here in the microscopy, as it is malignant tumor, of course glands will be present, plus there will be malignancy, that will be invasion, associated with invasion. And we have no mucin here, right? No mucin here. Understood? Okay, let's now move to our last, that is a clear cell carcinoma. Okay, so talking about clear cell carcinoma, the last tumor which I have to discuss. So what is the precursor lesion? Again is the endometriosis, which is the precursor. Okay, and in the microscopy, of course, we'll have this type of appearance. You have seen this appearance somewhere, right? This type of appearance, and this is called a hobnail appearance, right? Hobnail appearance. So we have a characteristic hobnail appearance associated with this, plus we have some clear cytoplasm, right? The cytoplasm of the cells are clear, plus clear cytoplasm. This is the microscopy. And here in the mutation, or you can say immunohistochemistry, IHC, we have the napsin A. Okay, so that finishes our ovarian tumors. Of course, I covered it in a very short way and a very non-comprehensive way, because we don't require that much. Okay, so this much is sufficient for a NEET PG as well as the prof exams if you can write, basically. So that's all in today's lecture. Let's meet again in any other lecture with any fresh topic. Until then, bye bye and take care.